All right, I think we could start. Good morning and welcome to Hamilton Health Sciences Department of Medicine Grand Round. I'll start with land acknowledgement. I want to acknowledge that I'm currently situated upon the traditional territories of the Hadensawnees and Mississaugas. This land is covered by the Dish with One Spoon, One Bun agreement between the Haudenosaunee and Anishinaabeg, and all of us on this land to share and care for the resources around the Great Lake. Understanding this is a virtual event, some of us may not be situated in the same land, so I will ask you to take a moment and reflect on people who came before us on these lands and that we currently reside on. Okay, we're pleased to have today Dr. Aiman Alak as our speaker. Dr. Alak is an assistant professor of medicine in the cardiology, electrophysiology, pacing, and heart failure. Aiman attended medical school at Western, completed his internal medicine and cardiology residency training at McMaster, and did his fellowship in electrophysiology, pacing, and advanced heart failure at McMaster and UHN. He's currently completing his master's degree in quality improvement and patient safety. Aiman's practice is mostly at the Hamilton General and the Heart Function Clinic and the electrophysiology service, linking those two very important cardiac services together. As expected, Aiman is talking to us today about heart management of heart failure in ICD. As usual, we'll have the presentation followed by Q&A. If you have any question, please have it in your in the Q&A section. If you have any comments, you can put it in the chat, and we'll moderate the questions at the end. Without further ado, Aiman, please go ahead.
Thank you, Khalid, and thank you everybody for inviting me to present today. So my disclosures are none. The objectives for today is to review the role of optimal medical therapy in patients with heart failure with reduced ejection fraction, also known as HEFrEF. To review the role of implantable cardiac devices in patients with HFrEF. Review the current status of patients' medical therapy in our ICD clinic, which is our local QI initiative. And we're going to present preliminary findings of a QI initiative, quality improvement initiative in this area. So as everybody in medicine knows, heart failure is on the rise in Canada. 600,000 Canadians are living with heart failure, and about 50,000 are diagnosed each year. And it's a very costly illness. It costs more than 2.8 billion per year. There's frequent hospitalizations. Those hospitalizations are long. The disease itself is complex. There's multiple comorbidities. We don't have cures, but we do have management strategies. The symptoms are broad, but it doesn't also affect just the patients. It affects their caregivers as well. This slide always impresses me. We're learned to deliver the diagnosis of cancer as bad news, and we get training in that area. But we rarely present heart failure as something as a grave prognosis. But in fact, when comparing the prognosis of heart failure in males and females, it's in fact worse than many cancers. So in females, it's worse than ovarian cancer, bowel cancer, and breast cancer. And in males, it's worse than bowel cancer, prostate cancer, and bladder cancer. And so that's how grave this condition is. Now, the therapeutic approach for patients with reduced ejection fraction. So this was the second most recent update, and I'm just going to skip that because it's been updated recently within the last year, and it's been streamlined in terms of the approach. And so on the basically any patients with an LVEF of less than 40% and symptoms, which is basically everybody, there's 4 cornerstones of therapies now. So we used to start with an ACE or ARB, but now we can start with an ARNI right off the bat. And then we also have beta blockers, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. So that's what I'm going to be referring to as quadruple therapy. Prior to this update, it used to be triple therapy with these other 3 agents. And then based on the patient's clinical response, they can be assessed for further therapy. If they're in sinus rhythm with an elevated heart rate, ivabradine could be considered. If they've had a recent heart failure hospitalization, they can be considered for varisequat, but that has not been approved yet. For Black patients on optimal goal-directed medical therapy, or if they're unable to tolerate ACE or ARBs or ARNIs, then we can consider a combination of hydralazine and nitrates. And for patients with suboptimal rate control for atrial fibrillation, or patients who are persistently symptomatic, we can consider digoxin. And the newest standard of care is to really do this as quickly as possible. And within 1 month, they should be at least on quadruple therapy. The recommendation is to titrate every 2 to 4 weeks to the target or maximally tolerated dose of no longer than 6 months, and ideally it should be within 3 months. Once we do that, we then reassess their ejection fraction, their symptoms, and their risk. If they're NYHA 3, 4, if they have some markers of advanced heart failure, then we consider referring them for advanced heart failure therapies, which is mechanical circulatory support or transplant, or for palliative or supportive care. If their ejection fraction is less than 35%, then they can be considered for devices. If their ejection fraction is more than 35%, and if they're truly NYHA class 1 and no risk, then we continue following. And in addition to this, just the medical part, it's important to educate the patients, perform non-pharmacological therapies with self-care, monitoring, exercise, participate in advanced care planning, treat the comorbidities, and titrate the diuretics. And really the diuretics, we should get them to as low dose as possible. And this, I think we're quite familiar with this data now that the ARBs have some benefit, the ACE inhibitors have some benefit, but when in Paradigm HF, clearly the ARNIs had an incremental benefit of 20% decrease in cardiovascular mortality on top of the ACE or ARBs. And furthermore, in the last couple of years, we've had very good evidence supporting the use of SGLT2 inhibitors, that they reduce cardiovascular death and heart failure hospitalizations. So here on the left side, it was a study for empagliflozin compared to placebo in yellow. And there is a reduction with a very strongly statistical positive p-value. And similarly here on the right side, the study from 2019 from Dr. McMurray et al. Showing the benefit with dapagliflozin. And that was the basis of why now we implement quadruple therapy for heart failure. And so to summarize, we're really talking about 5 different biochemical pathways and 4 pillars and some additional things that we can add. And so these 5 pathways are the angiotensin 2, norepinephrine, aldosterone, neprilysin, and the SGLT pathway. And the 4 drugs are the ARNIs, or if the patient has low blood pressure or other concerns, then we can consider starting with an ACE inhibitor or ARB and switch them when tolerated. The beta blockers and the ones that are heart failure proven is the carvedilol, bisoprolol, and metoprolol succinate. MRAs being spironolactone and allopurinol, and the SGLT2 inhibitors being dapagliflozin and empagliflozin. And then we talked about the 3 others that may have a role in specific subpopulations. And in terms of devices, so the devices go back quite a long way. This is one of the original main studies back from 2005. This is the SCD-HEFT study that showed that ICD reduces mortality across a spectrum of heart failure patients, much better than placebo. Amiodarone, there's no real difference from placebo. This looked at both ischemic and non-ischemic patients with an LVEF of less than 35%. And the follow-up was at 45 months. And here, ICD therapy versus placebo with a hazard ratio of 0.77 and a p-value of 0.007. And then the studies that supported CRT is one of the main ones is called the companion trial. And again, this is many years ago now, showing that CRT, and here what they looked at with both CRT pacemaker or CRT defibrillator improves and reduces mortality. And this study had about 1,500 patients symptomatic with an EF of less than 35% and a QRS of more than 120, but mostly they were more than 130. And the heart failure hazard ratio reduction for mortality was 0.76 for CRTP and 0.64 for CRTD at 15 months. And so this is the basis of how we assess patients for implanting cardiac devices. So if the patient has an ischemic cause of their heart failure, we get them on optimal medical therapy and assess their ejection fraction after 3 months. And if it's less than 35% by some reliable method, then we assess their symptomatic status. If they're symptomatic and they have a wide QRS, then they are eligible for an ICD CRTD. If they're in the other category, then they're considered for ICD only. And so that means even patients with NYHA1 and EF of less than 35%, if it's ischemic, then they can be considered for an ICD. The patients with non-ischemic cardiomyopathy, again, so before it used to say wait for 9 months of after optimal medical therapy, but we realized that that's too long, and most of the benefit in EF occurs in the first 3 months. And so we get the patients on optimal medical therapy for at least 3 months, reassess their EF, and if it is less than 35%, and if they are symptomatic, being NYHA2 or 4, then they can be considered for a device. If they have a wide complex on their ECG, then they consider for CRTD, otherwise it's an ICD. The caveat here, to be honest with you, it's incredibly rare for somebody to have an EF of less than 35% and truly be NYHA1. And so this, essentially this is that the vast majority of patients. Now in our ICD clinic, so when I put my EP hat on and we see patients with device shocks, we're treating them with antiarrhythmics and referring them for ablations and other advanced things. But when the analysis was done, looking at what happened to these patients with shocks, in fact, it turned out to be that heart failure is the most common cause of death after a shock from a device. And so this is an analysis from 2008. Here on the top, looking at appropriate versus no appropriate shocks. And even here it says no inappropriate shocks. So having an appropriate shock increases the hazard ratio for death by almost 6-fold, with a ratio of 5.68 and a p-value of less than 0.001. And when you take into account 2 appropriate shocks, that ratio becomes 8.23, which is that's quite drastic. And here they analyzed by the different types of death. So they looked at sudden arrhythmic death, heart failure, other cardiac causes, non-cardiac causes are unknown. And by far, heart failure here is the most common cause of death for these patients. And here, this analysis looks at the incremental benefit of adding all the agents. And so the main message here is that adding a ARNI, a beta blocker, an MRA, and even ivabradine, we have a good reduction in all the real major outcomes: mortality, cardiovascular mortality, hospitalization for heart failure. And actually, when this was done for SGLT2 inhibitors, these findings are consistent when quadruple agent are applied. This is an analysis that looks at ARNIs. And in this study, they took patients with implantable cardiac devices and they assessed them on ARNIs compared to ACE inhibitors, and found that there's a survival free from appropriate ICD shocks with ARNIs compared to just an ACE or an ARB with a p-value of less than 0.02. And this is admittedly a small study of only 120 patients. When they divided up to look at both non-sustained VT and VT, that's the benefit there is still consistent. Here, VT at the top, non-sustained VT at the bottom. And look, this is presenting the similar data about the non-sustained VT. Looking at PVCs per hour, which could really interfere with CRT pacing and decrease that percentage. And the higher the percentage we get with patients with CRT, the better their outcome. Here they found that ARNIs also reduced the number of PVCs per hour on average with a strongly positive p-value of 0.0003. Looking at AFib episodes, a borderline reduction, but it's not statistically significant. And then the biventricular pacing. So here, this is probably related to the reduction in PVCs or potentially reducing in some of the AFib episodes, that with the ARNIs, beta blockers, and MRAs, they do better than just angiotensin inhibition alone. And the difference is 98.8 compared to 95%. And so this is quite interesting. And the thought is that ARNIs may have some antiarrhythmic effects as well. And so there's a idea that these medications reduce myocyte death, hypertrophy, fibrosis, and inflammation. And together, this has an effect on reverse remodeling and a positive antiarrhythmic effect. In particular, the neprilysin inhibition is thought to increase enkophilins, endorphins, and bradykinin. And these are the agents that may exert some antiarrhythmic effects. Now, how are things going in large registries in the population? And so this is analysis of the CHAMP-HF registry, which is from the United States. And here we have the 4 classes of medications: the ACE/ARBs, the ARNIs, the beta blockers, and MRAs. And in orange, this is the stable subtarget or no medication, and green is stable target. Blue is initiation or dose increase over the follow-up of the study, and this yellow is discontinuation. And the main things to look at are: 1, look at the number of patients on a stable or target dose, 8.5% for ACE, 1.5% for ARNIs, 18.4% for beta blockers, and 22% for MRAs. And then in terms of room for improvement, 73% are on stable or subtarget or even no medication at all in the ACE/ARB, 86% for ARNIs, 65% of beta blockers, and 67% for MRAs. And the blue here is when there's some initiative taken, some change was made, and it's in the range of about 6 to 10%. So only over a long-term follow-up, only 6 to 10% of patients have their medications aggressively intensified. And this is presenting the data in a different way, looking at what percent of the patients are on a target dose. Gray is not receiving any medications. Orange is about less than 50%. Yellow is 15 and 99%, and 100 are target doses. And here we can see the trends for beta blockers and MRAs. again, reflecting the same message. And looking at 12 months compared to start of the follow-up, a very small number of patients had a total dose increase. And in fact, it's almost balanced out because there's many patients who ended up having a dose decrease. And so it turns out that not too many patients overall as a percentage had much change. Again, now looking at ACE or ARBs, we get a similar pattern. And then for ARNIs, this study is from 2019, so the ARNI uptake was still increasing, so it increased marginally here. And when looking at the reasons for suboptimal doses or discontinuation, not all of them are in fact medical reasons. And so just taking examples of ACE or ARBs on the left and ARNIs on the right, the medical reasons were about half of the time. So things like renal failure, electrolytes, or hypotension. But all the other things are, for example, health team reason or the team choosing not to do it, and 34%. System-based reason, for example, coverage. And then in some patients, and certainly we get this a lot, about 5% to 10% of the time, the patient says, oh, I feel fine, please don't change my medications. So those are all serve as areas for intervention. And this analysis shows that the better medical therapy is associated with improved outcomes. So this is the percentage cumulative death on the left and the survival time on the x-axis. And the black line is when patients are on the optimal doses of both ACE inhibitors and beta blockers, and the blue line is less than 50% dose of ACE inhibitors and beta blockers, and the green and red are in between. And here we see from these survival curves clearly, the higher the doses that the patients are on and tolerated, the better their outcome is. And so we decided to look into our own ICD clinic and see what the status is. So based on what I presented, basically all ICD patients, the vast majority have heart failure with reduced ejection fraction based on their indication. And so we collected this data in February 2019 for 10 months, and we gave the questionnaire to all patients with CRT-D devices. And we assessed them for the following symptoms. And so all the patients, they would complete whether, have they had more shortness of breath? Have they had to sleep on more pillows? Have they been more awake in the night feeling short of breath? Have they felt their abdomen to be more swollen? Have they had an increase in their water pill, or if they had heart failure, hospitalization? And we tried to also get their current cardiologist name. And if they answered yes to any of these things, we considered that questionnaire positive. And from that analysis, we had 143 patients. And the following are the device indications. So blue is CRT-D for primary prevention, means they haven't had an event. That was represented by 86% of patients. CRT-D implantation for secondary prevention was in 11.2%. CRT-P for heart failure indication was 4.2%. And then patients who are going to have an AV node ablation and they have LV dysfunction, that was 5.6%, and for bradycardia indications was 4.2%. And the average EF, not surprisingly, at or just before implant was 28%. When we looked at EF evaluation post-implant or most recent, 69 of the patients, or 45%, almost half of them, either didn't have it done, documented, or it's available. 6 of them had the test ordered and waiting to be done, and 77 of them, or another half, had the procedure completed, and their average ejection fraction was 41%. This was initially, back in 2019, less than 1% of the patients had their blood pressure recorded during the clinic visit, and we've improved that significantly. About 9 had an admission to hospital with heart failure. 3 did have appropriate therapy from their CRT-D, and their bi-VPASing percentage was actually quite good at 96%, 96.6%. And we looked into So when we first analyzed this data and we're providing an update, that was before SGLT2 inhibitors became strongly recommended. So I'm only going to present the data we had analyzed. And we looked at triple therapy at baseline. Blue here is none. The orange is 1 to 49% of target dose. Gray is 50 to 99%. And this yellow here is at 100%. And so looking at ARNIs, 64% were not on any. 8.4% were on 100% of the target dose. And then the others are in the intermediate doses. For ACE or ARBs, 54% were not on any, and 12.6% were on the target dose, and the remaining are intermediate doses. For beta blockers, 7% were not on any, 20.7% were 100% of the target dose, and 43% were on 50% or less of the target dose, and the remaining 30% are just a bit higher than that. And then MRAs here, 51% of patients were not on any, and only 2.7% were on the target dose. So again, re-emphasizing the findings that there's lots of areas for improvement. When we, some very rarely patients didn't have any lists, so that 14 of them, so we don't have that data. 138 were at least on one of the class of medications. 46 or 33% were on triple therapy. And that's very low. 58 or 42% were on double therapy, and only 6 of the patients, or 4%, were on the highest doses of ACE, ARBs, ARNIs, beta blockers, and an MRA, and only 1 patient were fully optimized. Only 13 or 9% were followed by a heart failure specialist, and otherwise patients were followed either by a cardiologist, an internist, and many of them didn't even have any subspecialist. It was only their family doctor. And so we saw this as an opportunity to try to improve patient care and therefore improve patient outcomes. And so when the patients would come, this was our flow diagram of how we approach this issue. And so the patients would complete their questionnaire, and if it was, we decided to focus on the patients with positive findings as they were a bit of higher risk. Those patients would immediately get assessed by our nurse clinician or nurse practitioner, and if heart failure is confirmed, then we refer them for further assessments. So if they have close follow-up in the heart failure clinic, or they have a cardiologist who's closely following them up, then we provide this information in a letter with some direction on what we suggest, but leave their follow-up to their primary specialist. However, there were a lot of patients who didn't have close follow-up. And so for those patients, then we initiated the referral. So we referred them to our local device and medication optimization clinic. That's the local QI initiative that we started. Or if appropriate, or based on patient choice, we refer them to either cardiologist or heart function clinic. But the easiest way to get patients in to be quickly assessed was through our DMA clinic for short. And so we started this during COVID. We were trying to start it since I came back, but of course, there's the usual hurdles with the administration cost and resources, but we were able to start it for about a year now. And because of COVID, this was an opportunity to do a lot of virtual or telephone assessments. And when we analyzed our data last month, we've now had just around 99 patients, almost 100 patients. That was our initial target, was if we can get 100 patients before the end of the year, we considered that a success. For these patients, the age was 70.1 with a range of 10.3 years. 74.7% were males. About half of them had coronary artery disease or previous CABG. Their left ventricular ejection fraction is 32.8%. 23.2% had a heart failure admission in the last 12 months. The baseline creatinine was 110.8, a standard deviation of 56. 76.7% were on either an ACE or ARB/ARNI. 86.7% were on a beta blocker any dose, and 34.3% were on MRA. And this is looking now at the changes we've done. And so the goal of this DMOC clinic is it's not meant to be a substitute for the heart failure clinic, but it's meant to be as a bridge, at least for these patients that are not closely followed or a bit orphan, to get some medical optimization before we can connect them with another specialist. And so here is the data for the ACE, ARB, or ARNI use. The blue is in baseline, and the orange is the change in our clinic. So for the ACE inhibitor, about 30% of patients had a change, being a dose increase or initiation, and about 5% for ARBs. For ARNIs, that was about 50% of patients had a change. And when we broke down the summary of our changes, 44% had a new ARNI start, 17% had a ARNI dose change or increase, 12% had a new ACE start, and 27% of the change was an ACE dose change. And for beta blockers and MRAs, we had 90% of patients for beta blockers, we changed their dose, and 40% of patients, we've changed their dose or initiated them. And so moving forward, our goals is to continue to optimize current patients, to analyze data on SGLT2 inhibitors because the data is quite supportive of that, and potentially other medications. We'd like to continue to recruit patients into a clinic. We would like to collect a bit more data and assess reasons for sub-target dosing and see if we can tailor our intervention to those patients. And we're also looking into collaborating with other centers to make this a multi-center initiative. And so to summarize this presentation, quadruple medical therapy for patients with heart failure with reduced ejection fraction improves morbidity and mortality. Achieving target doses of medical therapy is associated with improved outcomes. The ICD clinic presents a unique opportunity for improving medical therapy, and our local quality improvement initiative started has already been improved medical therapy and can present a national and international model for the collaboration between the arrhythmia and heart failure services. And so these type of initiatives are only possible with the support and collaboration with many people. So my main partners in the clinic and the staffing of the clinic are Dr. Jeff Healy and Dr. Jorge Wong. We of course needed the support of our EP department head, Dr. Guy Amit. Dr. Lucy Paul is our nurse practitioner, and she had started some of this analysis, and she is one of our main partners. Dr. Nilu Ahmed Beji is a heart failure fellow who's helped us, and she with this clinic. Judy Van Ness, the manager support, and Shelley Rhines, the clinic administrator, who's kept track of all our referrals and made sure we're on track with our appointments. So thank you, everybody, for taking the time to participate, and we can open up for questions and discussion.
Thank you, Aiman. That's a fantastic presentation. Just want to remind everyone, if you have a question, just please put it up in the Q&A. If you have a comment, put it in the chat. And if you want to come in and ask your question in person, just raise your hand and I'll pull you into the, give you permission to speak. So it looks like, there is a question, a long one from Dr. Satya. Thank you for the great talk. A few questions. What do you do with patients with ejection fraction more than 40%. So this is the less more like a preserved or mid-range patients, and that's a big discussion. You want to comment briefly on that, and then we'll move on.
Yeah, so I think there's a range there. That's a very important question. So the heart failure with reduced ejection fraction, that's the area where we have the most evidence. The heart failure with preserved ejection fraction, so it used to be a cutoff of 50%, but really normal is close to 55 or 60%. Those patients, so we don't really have strong evidence for that area other than treating for risk factors, decongesting them, treating their comorbidities like hypertension, coronary disease, and atrial fibrillation. Most recently, there's the evidence supporting a use of SGLT2 inhibitors for patients with heart failure with preserved ejection fraction. And that's showed it's finally the first study to be truly statistically positive for the use of those for finally a group. And so now we're using SGLT2 inhibitors in heart failure with preserved GF. Now, what you're asking about, so are those two categories, is the EF of 55% or so, those patients I may use, treating the underlying risk factors, education, et cetera. And the two agents I may use are the SGLT2 inhibitors and the MRAs. And the use of the MRAs is based on the TopCat study, where that in the North American population there was a benefit, but in the overall study it wasn't benefit. But I'm reaching out here a little bit and using that because we don't have much else. I think with heart failure with mid-range ejection fraction, it's now we have more data to be supportive. So those patients that are in the range of 40 to 50% or so, I'm still comfortable with using quadruple therapy. And that's supported by the Paragon study and the recent SGLT2 study. So that's my overall approach. Now, the second question is that most general physicians are seeing patients when they get readmitted with pulmonary edema. So if they're on quadruple therapy, then is it still recommended to still use diuretics? GTN infusion, is that nitro, or would you titrate up their spironolactone SGLT2 inhibitor? Yeah, so that's a great question. I mean, I think I would do both. We in the acute phase diurese them because we have to get their symptoms under control. Use nitrates if you need to, but take it as an opportunity to use to initiate a class of medication that hasn't been started, or to optimize something that they have already started. So as they're not, the doses we use for spironolactone SGLT2 inhibitors, they're not very strong diuretic doses, but they can help you in other ways. So the spironolactone is a potassium sparing diuretic. So instead of dumping patients on oral potassium replacement, my go-to is to optimize their MRA dose. And then we have other patients who may get borderline hyperkalemic, and that would limit initiation for some other agents. And so for those patients, I try to get them on the right dose of SGLT2. Now, there's not much to optimize in terms of the heart failure. It's only one dose for dapagliflozin and pagliflozin. It's just 10 milligrams. So it's not like the diabetes where there's a bit of a range in doses. So that's kind of my approach there. And the third question says, I was surprised by the aggressive heart rate control. Add ivabradine. To what extent will this limit the increase in the heart rate required to exercise, and will this limit the functional quality of life? Yeah, that's a good question. So from a prognostic perspective, and when we divide it up by various heart rate ranges, the patients with heart failure, and we get them to a heart rate of 50 to 60, they do far better than the patients with the higher heart rates. And so when I get a new patient with heart failure, if their heart rate's in the 90s to 100, that's actually a big warning sign. And so we try to modulate that heart rate. And does this limit their functional quality of life? It's in fact the opposite. So for example, in the ivabradine study, that was done to decrease the heart rate, and it was added on top of the beta blockers. And it showed a reduction in heart failure hospitalization and also cardiovascular mortality, although mostly it's heart failure hospitalizations. And so they found that it increases the quality of life. Of course, you may have some patients with severely restricted chronotropic incompetence. Those would have to be assessed on a patient by patient basis, but by far and large, getting them to target heart rate would do them the most benefit, both in terms of quality of life, reducing heart failure hospitalizations, and reducing mortality.
Thank you, Aiman. There are a couple of questions in the chat, actually. So there's one from Dr. Carnot asking about should the ICD trial be redone in view of changing therapy and older and sicker patients who cannot get the target doses because of low blood pressure, falls, and other risks?
Yeah, so I mean, it's always good to do more studies. I think I would never disagree with that, to get more information. I'm less concerned about just redoing the trial. I'm more concerned about trying to pick patients who may benefit or may not benefit, because I mean, looking at it, this is very crude. I mean, we're using this one number, this ejection fraction of 35%, and saying, oh, if you have this number, then you get an ICD. If you don't, you don't get an ICD. And I find that incredibly simplistic and pretty poor in the big picture of things. I mean, it's a good predictor, but it's not the only predictor. So I strongly agree. I think we need to do more and more studies to try to define who are the patients who are really going to benefit from ICDs, who are the ones that aren't. Now, what about a patient with an EF of 40%, but they have regional wall motion abnormalities and they have abnormal electrical alternance or abnormal heart rate variability? Would they benefit? I'm not sure, but I think that area needs to be studied. And certainly there may be a role for using MRIs as well, looking at the ischemic burden or the scarring burden. So that's certainly an area of ongoing study. Now, as far as currently, I think that what we know is that the longer the patient survives, the more likely that they are to benefit from an ICD, because the ICD may likely kick in and save them from a ventricular arrhythmia. So in fact, these medications are newly started and that they're increasing survival. This in fact, I think this in fact will show more benefit for the patients with ICDs will show more benefit. It's the patients that won't survive very long. It's the patients with survival of less than 1 year. So like the one you mentioned, the elderly, very frail patient who can't tolerate medical therapy, they're having recurrent heart failure hospitalizations, or they have a cancer or something like that. The ones that are not going to survive more than 6 months or a year, those are the patients who are not going to benefit. But these have been analyzed. So when they looked at the paradigm study, or when they looked at the SGLT2 inhibitor studies, when they looked at ICDs, the benefit was still consistent. But otherwise, I agree. I think we need more studies to try to tailor define a bit who will really benefit, who won't. And I think EF is just too crude.
Thank you for this perspective. This question from Aram asking about the aggressiveness of the timeline to reach quadruple therapy. It's clarifying, is it a 1 month based on trials and consensus, and whether would that aggressive approach lead to adverse effects like hypertension, kidney injury, and others?
Yeah, so that's based on both. From the studies, the benefit, patients get benefit within a month of initiating therapy when looking at the different Kaplan-Meier curves. And that's the rationale why we should start them all as quickly as possible instead of waiting. So the old classical approach, and when I started back when I was a student, we used to think, okay, start the ACE inhibitor, get that maximum dose, start the beta block, get that maximum dose, do that with MRE. And no, now we know that that's in fact probably wrong, because instead you can focus on 4 different classes, target those 5 different biochemical pathways, and those patients, the earlier you start them on, the more benefit you get. In fact, one of the heart failure world experts, he actually suggests starting all 4 agents on one in the first visit. I think I'm still too young. I'm not that brave to do that altogether, but certainly I'm more accepting of trying to start 2 agents at a time, or instead of changing 1 dose at a time, if the patient has enough room for blood pressure, their heart rate, their kidney function, electrolytes, I'm very comfortable with changing 2 medications at a time. And I mean, for example, in MI, we don't get worried about starting an ASA, dual-length plate therapy, an ACE, a beta blocker, or an MRA. We don't get too worried about starting that. And I think that's the same with heart failure. One of the biggest interventions is that people get more comfortable optimizing doses. And so now when I'm rounding in cardiology and I have a heart failure patients, all my patients are on quadruple therapy and for good doses within 3-4 days, if possible. And if the patients are picked correctly, then there shouldn't be too much adverse events. Of course, if the patient is hypotensive, their electrolytes are out of whack, they have an acute kidney injury, I mean, those are not the patients to be doing this on. I'm talking about once we've optimized the patient a bit, got them a bit more euvolemic, stabilize them, that's the time to be doing these things.
You bring in a very good point, Aiman, around, inpatient, and that wasn't the purpose of this talk, but, aggressive therapy prior to discharge is probably what you're doing in your practice, and making sure the patients are discharged on the proper medications. What about the use of beta blockers in acute setting? I know that that's been in the past as an arguments for and against. Do you want to comment on that?
Yeah, sure. So for patients that come in with a heart failure exacerbation, if they're on a beta blocker, they used to get, when they come in with a heart failure exacerbation, that used to be discontinued. But when looking at the studies, it found that those patients, in fact, had worsening mortality. And so the approach is that for patients already on a beta blocker is to continue the current beta blocker dose until they're out of a heart failure exacerbation. For the patients that are not on any beta blocker, we know that initially beta blockers are negative inotropic agents, so they can make the heart failure acutely worse. And so my approach is that if the patient has significant pulmonary edema, particularly orthopnea, PND, I don't start beta blocker at that time. I wait until they're a bit more decongested, and then initiate it, being in mind that a small % of patients may decompensate a little bit initially, but that's a very small subset of patient if we waited just enough.
So Imran has a follow-up question about the use of BNP in titrating as a biomarker in titrating your medication. Is that the practice you do, or do you advise doing that, doing a bit of a costly test?
Yeah, so BNP, it has a good use in prognosis. And so when I'm trying to assess, is the patient going to be at a long-term adverse prognostic event, I try to get a BNP, and that's included in most of the heart failure score, like the Seattle or the Miracle scores. And the other use for it it's actually recommended, very rarely done, I'm sure, is that when a patient comes in with heart failure, you get a baseline BNP, and then before discharge, they should be at least 35% or so, 30 to 35% decrease in their BNP. And those patients that have that decrease in BNP, they're less likely to have a heart failure hospitalization. But otherwise, I don't routinely measure BNP to optimize targets. So like I said, the patients they should be on the maximally tolerated dose. And even the patients who say they're not too symptomatic, I mean, we had one patient in heart function clinic. They said, oh, I'm fine. I have no limitation. You would think maybe they're NYHA1, but we did a cardiopulmonary exercise stress test, and their VO2 max was 5.9 mil per kilogram per minute, which is severely reduced. That's the cutoff for transplant is about 12. And so I don't target medical therapy based on BNP. I use it for prognosis, and when possible, to try to make sure that I've treated the patient enough before discharging them from hospital.
And does that apply for both reduced and preserved ejection fraction heart failures, or is that more of the reduced one?
Yeah, I mean, definitely in the reduced one. In the In the preserved, it's a bit more tough. And to be honest with you, I would need to look up the studies to see if that's been used. The reason why I'm cautious in preserve, I would still probably use it in preserve, but again, I would have to look it up and see if that's been confirmed, because for some reason the BNP tends to be less elevated in patients with heart failure with preserved ejection fraction, and in rare cases not even up that high. So most of the evidence I suspect is in the reduced.
Thank you, Aiman. And this is a medicine background. We see a lot in GIM, preserved ejection fraction heart failures, but occasionally we see the reduced ones. There was a follow-up question from Dr. Curnow about the cost for ICDs and biventricular devices. These days, any idea about? I mean, I'm sure you know.
Yeah, I mean, luckily they're covered by OHIP, but we had one patient about a year ago or so. They're from the US, and it's quite expensive. It's 10,000-20,000 easily per patient, and then of course you're going to need follow-up visits and things like that.
Great. I don't see any more questions or any discussion in the chat. This has been fabulous. I mean, a good overview of a very important and evolving area of knowledge, and a great interactive discussion that's very practical. Greatly appreciated. And thank you for your time and joining us today. And I want to thank everyone for joining this morning. We give you back a few minutes to catch up before the rest of your day. Have a great day. Thank you.
Thank you, everybody, for inviting me. Take care.
Thanks.